Welcome to the Hearing Review's webinar, Building a Business with Physician Referrals, presented by Brian Taylor, Bob Tysoe, and Brad Dodson. I'm Carl Strum, editor of the Hearing Review magazine and its website at hearingreview.com. In this three-part webinar, we'll be exploring physician referrals and how you can better position and promote your practice, both today and in the future. Each part of the webinar runs about 20 minutes and features an acknowledged expert in this area, and we're blessed to have a really all-star international panel today. Part 1, presented by Dr. Brian Taylor, will look at how audiology and hearing healthcare fits in with the evolving medical landscape and what we can probably anticipate, or more specifically, what we should be doing to prepare ourselves for the future as hearing healthcare inevitably becomes a more integral part of patient care. Dr. Taylor, who resides in Minneapolis, is the Clinical Audiology Director of Fuel Medical. He serves as an editor for several hearing-related media and has been a key opinion leader in the hearing healthcare field for over 25 years. Part 2, presented by Bob Tysoe, is going to provide a tutorial on physician marketing, leveraging Bob's many years of experience in the pharmaceutical field to give you an idea of just how the typical physician clinic operates. And he'll be also providing a lot of great insider tips for gaining the ears of physicians, and just as importantly, the nurses and staff members that support those physicians. Bob, who hails from Australia, is the founder of a hearing healthcare marketing company in Portland and is well known in our field for his expertise in physician marketing. And last, but certainly not least, Brad Dodson in Part 3 will introduce you to digital marketing for physicians and their patients. In his 20-minute segment, Brad will show you some of the latest digital multi-layering marketing techniques for engaging physicians using emails and the brave new world of mobile geo-fencing, a way in which data from apps and smartphones can be honed to perfect your marketing outreach. Brad, who is from South Africa, is the VP of Sales for ClearSound's Communication in Chicago and is also heading up MD Emails, which also utilizes Bob and Brian's expertise. Today's presentation is brought to you by CareCredit, a hearing healthcare credit card designed for patients' health, beauty, and wellness needs. It helps families access the care they need and want without delay or compromise. Approved patients with hearing problems can use it to pay for hearing tests, aids, and other preventive hearing devices that they need to live their lives to the fullest. As a matter of housekeeping this webinar, you can email questions to any of the presenters via the Q&A box on the left or by using the email addresses shown at the end of this presentation. And on this slide, you'll see the standard ever-present legal disclaimer, which essentially says you are urged to consult with financial, legal, and other advisors relative to this content, and there's no implied liability for the use of the information provided. And with that, let's start off with Part 1 of the webinar with Dr. Brian Taylor. Brian?
Greetings, everyone. I'd like to thank CareCredit and the Hearing Review for providing the opportunity to do this. I'm really excited to be with you, and I hope you find this to be an informative session. Disclosures to get out of the way. Currently, I'm the Director of Clinical Audiology for the Fuel Medical Group, and I'm also the editor of Audiology Practices, which is the quarterly journal of the Doctors of the Academy of Audiology. And I'm also the editor of the Hearing News section for the blog Hearing Healthcare and Technology Matters. And finally, I serve as an advisor for a startup company called Resonance Medical, which is based out of Chicago. Some of my learning objectives today that I want to focus on. I want to kind of look at the big picture and how audiology and hearing healthcare fits in with the larger medical healthcare landscape. So I'll make an attempt to try to contextualize what we do in our fields with what's happening throughout all of healthcare. And with that, I want to talk about some of what I call the clinical equivalents. One thing I hope that you'll learn from me today is that there's a mantra throughout healthcare which focus on cost, access, and quality. And I think within our own sphere of influence, we have to focus on cost, access, and quality in the clinic, and how do we improve those three components. So I hope to provide you with some ideas on how you can do that as we move into what I think is a very exciting future, maybe a few roadblocks here and there, but for the most part, I want to paint a pretty optimistic picture of how hearing healthcare can really thrive within the evolving healthcare landscape. So to dive into this, let's ask ourselves this key question, which is seen here on the slide. And that question is, what role does medical and hearing healthcare play in society? Now, that's a pretty big question, and I want to look at it through the lens of history. This slide might be a little hard to see. This is kind of an interesting slide that looks at how healthcare has changed over the last 50 years. Now, this slide was put together about 7 or 8 years ago, but I think the trends are still pretty much with us today. And if you look at this slide, you'll notice it focuses on cost, providers, who pays the bills, the population, and some other health indicators, habits, and so forth. The two components I want to look at are cost and population. The first one at the top, cost, you can see pretty clearly over the last 50 years, cost has gone up dramatically. We went from under 10% of gross domestic product eaten up by healthcare costs to now almost 20%. So you can see cost is definitely a factor. And when you think about OTC and some of the changes around regulations, it doesn't come out of a vacuum. Cost, as probably everybody knows, is a big part of healthcare, one of the big questions that we try to tackle as a society. And then I also want you to look at the population. And it really jumps out at you at the number of people that live beyond the age of 60 now compared to back 50 years ago. In addition to more people living longer, we also have, because of the baby boomer population, just more of those older aging Americans, which of course associated with aging is hearing loss. So we have to think about this number of individuals that are out there that are struggling with their hearing coming into the office to see us. And one of the questions that we might have is, are there enough audiologists and hearing instrument specialists to support that population? And one of the answers to that question is, according to some of the experts, is no. There is a shortage of professionals to take care of the aging baby boomer population. So this slide really serves as kind of a summary of what some of the drivers of the overall healthcare market, what's happening with all of us. I also wanted to put a little context around what's changed in healthcare by thinking back 50 years ago. We just have to go back 50 years to know that there was a real intense focus in healthcare on infectious diseases and the treatment of acute conditions. If you were born 50 years ago, it's likely that your mother stayed in the hospital sometimes upwards of a week, which is extremely rare today unless there's some kind of an unusual complication. And if there's one word that sort of, I think, summarizes the kind of care that people got back 50 years ago, it would be the word paternalistic. The doctor was the all-knowing expert, and the patient was sort of the passive individual who was at the beck and call of the physician who made all of the decisions. But of course, today we live in a much different world where we focus a lot more of our resources on preventive care. At least we should be focusing our resources on preventive care, wellness programs, early identification, and shift more of the focus on the treatment of chronic conditions like diabetes, arthritis. You could even put dementia in that category, and certainly hearing loss. And if there's one buzzword or phrase that you hear more and more, it's this whole notion of patient-centric care. I think everywhere you go these days, you happen to see that phrase. We don't have time to really get into the details of what that might mean, but there's been some pretty dramatic changes over the years. So that brings us to the consumer perspective. So in all this, even though there's a lot of interest and people want to earn a living and organizations want to have their turf protected, which are all natural and normal kind of things, at the end of the day, it's the consumer and their perspective that really drives things. And one of the terms you also hear today is this whole is the idea of consumer-driven healthcare. And from a consumer-driven healthcare perspective, there are three components that I've already mentioned that we need to focus on. That is, how do we lower cost? How do we increase access, which means how do more people get our services? How do we make it easy for them to acquire our services? And how do we improve quality? So if you're a clinician out there working in your office, seeing patients, these are the three components that all of us need to focus on. I think sticking with the clinical theme here, it's important to remember that what happens inside your clinic is reflective of all of healthcare. In other words, what do we need to do to lower costs, increase access, and improve quality? And I call these the clinical equivalents, and we're going to talk about each one of these three things individually. Let's look at lowering costs first. And in my mind, this is really about how do we improve efficiency. One of the things I like to focus on is traditionally in the hearing healthcare world, it's the routine patient that really subsidizes the complex patient. So what does it mean that the routine patient subsidizes the complex patient? Well, it typically means that when patients walk in your door and they're a hearing aid candidate and they go through the process of acquiring a set of hearing aids, oftentimes we don't know which patients are going to only take a little bit of our time and which ones are going to take hours and hours of our time over a 1 or 2 year period. So I think we need to look for ways on how we can sort the routine from the complex. There's a couple of audiologists in Europe, David Stevens, who passed away a few years ago, and Sophia Kramer, that developed, I think, a really handy way to look at patient care. They developed, in their line of thinking, 4 different types of patients. You see them listed here on the slide that I think it's really helpful to try to figure out which bucket a patient might fall into. So, for example, after you've done an assessment, you may find that a patient is positively motivated and they don't have any complicating factors. That would be a type 1 patient versus a type 2, somebody that's maybe positively motivated to get help, but they have some complicating factors. Or a type 3, which is a person who wants help, but they're in denial or they don't recognize the magnitude of the problem and they reject a key component of your recommendation. And then, of course, there's the final person, type 4, who might deny that they have any issues at all with hearing and communication. So the question is how do you separate those routine patients, which would be a type 1 patient, from the other 3 types? In addition to trying to separate the routine from the complex, I think it's also important to think about what are some other alternative delivery models that might lower the overall cost of care and make working with patients more efficient. So you're starting to see some work in some areas around the use of community healthcare workers. I know at Johns Hopkins University, Frank Lin and Nick Reed and some of the other researchers there have been dabbling with the use of community healthcare workers to lower the cost and actually improve the access of care. Another alternative service delivery model to consider would be audiology assistants, taking some of the more routine work and delegating it to an assistant so that the audiologist in that type of a clinic would spend more of their time with the more complicated patients. We're also seeing the rise of telehealth or teleaudiology services. I know some of the hearing aid manufacturers are now bringing some products to market that allow us to do this more seamlessly. Another alternative service delivery model could be the use of automated, computerized screening, maybe on a kiosk. Now, that kind of technology has been around for a long time, but might be a way for us to be more efficient, with the end goal, of course, trying to separate the routine cases from the more complex. One of the things I've been looking at, and this is kind of in the preliminary stages, but I want to at least float the idea, is this, I call it the Communication Hexagram. And the idea here is during the initial intake with a patient, right now I would say this could be done face-to-face with any patient, but in addition to the routine audiometric findings that you gather, to look at ways to evaluate and rate the person's cognitive ability, their physical ability, their overall outlook or attitude or motivation, their self-perception of hearing loss, their self-confidence, and their family support. But the idea is to rate on a 0 to 3 scale each one of these dimensions. And if somebody has a rating of, say, a 3 or a 2 from the clinician on one or more of these dimensions, that's maybe more likely to make that person a complex patient. requiring more time and expertise on the part of the professional. Let's move to the second clinical equivalent, and that is increased access. Now, when we talk about increased access, we're really talking about how can we take those people that might have maybe a more routine challenge or problem, or maybe a milder hearing loss, and how do we allow them to have access to our services and our technology? Or how do we take people that maybe can't afford our services and technology and make it more affordable, or make it easier for them to get to the office? So one component of increasing access could certainly be some type of direct-to-consumer or over-the-counter device. And even if those devices were to come on the market, and it seems like in the next few years we're going to see them, I would say that hearing care professionals still play a very important integral role in making sure that if we increase access, that the technical quality and the safety of those products are up to par. And that means making sure that we have a say in how those products are labeled. It means that we have a say in predefining the acoustic standards of what those products should be doing in the ear, that we verify that those products are up to standard when somebody comes into the office using probe mic analysis. So even though these products are designed to be sold direct to consumers, I still think we play a pretty important role in how these products could be labeled and how they could be distributed and how they could be analyzed and checked if anybody ever came into your office with them. The last component of improving access, lowering cost, is to look at how we can improve quality. And the clinical equivalent of improving quality, in my opinion, is showing that our treatment plan and what we've asked the patient to do is then documented to be effective. And in the clinic, I think there's a couple of things you can do to stay in alignment with that mantra of lowering cost, improving access, and improving quality. And that is to focus on improving function and to document outcomes. And when we talk about focusing on improving function, really what we're talking about is making sure that in daily living, the patient is able to participate in activities that they're interested and want to participate in. That's actually called the International Classification of Functioning Model, which comes from the World Health Organization. And the ICF model is really nothing more than a framework for understanding the impact that hearing loss has on participation in daily activities. You see that there kind of on the right in a schematic form. From a practical standpoint, that's really about setting shared goals with the patient, focusing on how they want to improve daily activities and functions. A nice tool that kind of helps with this is the COSI that most people are familiar with, being very complete about how you use that, involving communication partners whenever you can. But rather than focusing on the test results and the technology, focusing on how we can improve daily function for the patient. And then, of course, with that comes documenting the outcomes to show that our treatment was actually successful. And there's a number of dimensions there. We have benefit, satisfaction, quality of life. And so the clinical tools that you can use to measure effectiveness of your treatment would be tools like the COSI that I've already mentioned, the hearing handicap inventory for the elderly, which has been around for a long time, but it's a very handy tool that you can do pre- and post-treatment to measure and document effectiveness. And then, of course, another one that I think is pretty handy is the International Outcome Inventory for Hearing Aids, which is a 7-question self-report that documents all the vitals around satisfaction, benefit, use time, handicap, disability, all kind of wrapped up into one simple-to-use 7-question report. So that's sort of a very, I think, relatively brief overview that helps contextualize the changing role of the hearing healthcare professional in today's world. And I wanted to kind of leave you with some final thoughts. One of them is to find a place for over-the-counter, direct-to-consumer devices. I think with the legislation now being signed by the President, it's just a matter of time before we see more of these products hitting the market. I would encourage you to find a place because for no other reason, if you look at what's called the stages of change model, which we don't have time to get into, these devices are a good thing for some of our patients because it actually encourages them to take action. And when a person takes action when they have a chronic condition, that can be a good thing. I think the challenge for us is how do we funnel those patients over to us that need extra help or may have had a disappointing experience. Another thought is I think it's really imperative for us to develop an unbundled service model. In addition to OTC, I think you see the rise of these Medicare Advantage programs as another reason to start unbundling a lot of the services that we provide. But I would encourage people to look at some unbundled models around service packages, maybe after the transaction of hearing aids, ways to separate long-term services for maybe more complicated patients that need them, find ways to unbundle those services so that they see that there's a value in what you provide. I would also encourage you to create a viable service model for OTC users that need professional assistance. So back to that hexagram I showed you, if somebody has a complicating issue, that probably means that the professional needs to get involved. And if you get involved, there should be a fee attached to the time and expertise that you bring to the table. And I also think it's an opportunity now in this changing landscape to think about how we can balance public health needs with those of the individual. There was a paper recently published, Blake Wilson, who's at the University of, I think at Duke University, was the lead author. The title of the paper is Global Hearing Healthcare, New Findings and Perspectives. And I think that's an excellent summary of the burden hearing loss places not only on the individual but also on the community and society in general. And of course, I think we have a role in raising awareness around the public health needs. And again, that whole notion of medical versus interventional audiology. Of course, medical audiology, in my mind, is identifying ear disease or site of lesion, making the proper referral if you find a red flag, making sure that you stick to all of the science around identification of those conditions. That's something that will always continue to be, I think, a vital part of what we do. But taking a public health perspective and raising awareness requires us to practice what I call interventional audiology. It's important if somebody comes in and needs assistance that because access and cost are important, can be important barriers to overcome, that we have some strategy for offering patient financing. And I think Care Credit is a great tool that allows you to overcome that potential barrier around cost. Not only does it help improve affordability and accessibility by offering a variety of payment options and payment plans, but it can cover more than just hearing aids. Tinnitus devices, ALDs, some of these other things that we talked about could potentially be financed through Care Credit. So it's good for you and your patients to know that. But back to when I was talking about interventional audiology versus medical audiology, I think a key component of interventional audiology is to be able to understand and communicate some of these downstream conditions that are associated with hearing loss. There's all kinds of research out there now that shows that patients with hearing loss are more likely to be socially isolated, to be depressed. They're more likely to have accelerated cognitive decline. And I would encourage you to view Dr. Abrams' outstanding webinar that did a great job a few months ago of summarizing those things using the key. He overviews the key studies. And I want to end by talking about, being a hearing care professional is a very noble profession. I think by and large we do a great job out there, and it helps that we remind ourselves, what do we bring to the table? And I think in this new future, the two things that we bring to the table, or will continue to bring to the table, are customization and counseling and education. The better you are at these two things, I think the more likely you are to be the go-to person in your community for hearing health care. So my message to you is to really focus your time and skills and attention on doing an outstanding job at these two things. So with that all said, I hope that you were able to take a few pointers away from it. And I wanted to introduce my colleague, Bob Tysoe, my friend and colleague, Bob Tysoe, who's going to talk about how you can gain the ear of the physician.
Thank you, Brian, for that kind introduction. And I want to say a special thank you to the Hearing Review and to Care Credit for sponsoring today's educational program. I'm honored to be part of the panel presenting information on physician marketing. As everyone is aware, change is upon us in the hearing healthcare industry, and more people are looking to the primary care physician as a potential referrer of new patients to their practice to solidify their place in hearing healthcare, to increase the number of patients who are referred from the physician, and to increase their revenue, to make sure that they ensure their financial survival and their professional survival. We're going to be presenting some concepts here today that are going to help you do all of those things. An important concept with physician marketing is the total office call. Everybody in the doctor's office, every staff member contributes to the patient care outcome either directly or indirectly. And while the physician is the busy revenue engine for the practice, you cannot judge the success of a physician marketing program by whether you see or don't see the doctor, whether you have educated the doctor or have not educated the doctor. You have to see as many people in the doctor's office as you possibly can, provide them with your value proposition, in other words, your content folder, so that we begin the process of educating them about the disease state of hearing loss, including the negative consequences of uncorrected loss, the benefits of care, and the reasons why they should refer their patients over to you. We need to keep an accurate record of each conversation with each staff member so that we can follow up with each one of them and so that they can see that we're committed to helping them in their responsibilities for taking care of the patient. Ultimately, what happens is you become an accepted member of their healthcare team. They rely on you for your expertise, and everybody in that doctor's office knows how to direct a patient from their practice to your practice. So we start with realistic expectations. We start with a concept called foot in the door marketing. It's an old marketing technique, but basically what it means is that we start with smaller requests in order to gain compliance with larger requests. It's not a manipulative marketing strategy. It is one in which we have to deal with the environment that we are in. We can't walk in and say, you've got 5 doctors in your practice, I want to see all of your doctors. No, you start with the reason why I am here today is to begin the process of providing you with improved customer service. And once you explain your value proposition, you want to leverage that information with the receptionist so that you can present it to the medical assistant, the referral coordinator, the clinic manager, so that you take a couple of minutes to explain what is in that physician referral folder and how they can use it as a patient care management folder. So start small with small requests. Later on, you can ask for a bigger request, and the idea is to get them to say yes in the beginning and to continue to say yes with small requests that ultimately lead up to a face-to-face conversation with the main decision maker in the practice, and that would be the physician. I also want to point out to you that my learning champion in every single doctor's office that I have ever called on is the medical assistant or the nurse. So just as important to make sure that the same information gets in the medical assistant nurse's hands as it is the physician's. So we say, as we see in the slide here, first concentrate on seeing the nurse or the medical physician. You can graduate to visiting with the physician in later calls, especially if you schedule a lunch and learn. Now, great content can get you in the door, and when I say great content, I mean clinical research articles about the disease state of hearing loss for the physicians. I also mean patient education material for the medical assistant to give out to patients who have been diagnosed with hearing loss, and that the physician has directed them over to see you for a baseline hearing evaluation and a routine annual follow-up. I also mean insurance and payment plan information for the referral coordinators. Not every doctor's office has one. Frequently, it's the medical assistant's responsibility. We should find out who does that in each practice, and we should make sure that we are in the computerized database of specialists to whom they would refer those patients. So you want them to have a choice of providers. Let's make sure that you're in their database of specialists, hearing healthcare specialists, to whom they can refer those patients. So the contents of your promotional folder will benefit the doctor, the nurse, the referral coordinator, the clinic manager, and it helps you as a sales and marketing tool, but it helps them as a patient care management tool, and it allows you to ultimately explain your value proposition about how you can partner with the doctor to improve the patient's care and their quality of life. Now, in medical school and in pharmaceutical company marketing training programs, the focus that physicians place for every patient who enters an exam room is efficacy, side effects, and cost. So with efficacy, that's their number one priority, and we have to focus a lot of our educational efforts on validating the treatment plans that we propose for patients so that we get them to efficacy. Now, we also have to talk about how we help the doctor get the patient to efficacy. So when a doctor says it works, that's the greatest compliment that they can pay to a medication, a treatment plan, or a surgical procedure. So in both medicine and audiology, efficacy is the ability of a new medication, treatment plan, or surgical procedure to improve the patient's symptoms so that that's an improved outcome. It's not a cure, but if we're improving symptoms, that doctor sees that as efficacy. So be prepared to explain the problems that you want to help them solve, especially the negative consequences of uncorrected hearing loss. Too often we assume they know what they are, but they haven't been through 7 years of audiology training or done a hearing instrument specialist training, and so they need us to educate them about the negative consequences of uncorrected hearing loss. And some of those are an increased risk of falls for patients who are elderly, who have high-frequency hearing loss, and potentially have vestibulopathies, coexisting vestibulopathy. It also means an increased slide into cognitive function decline / dementia. It also means the risk of being laid off from the job because of poor communication issues related to hearing loss. It also means social isolation and depression, and ultimately earlier mortality. Physicians are not familiar with this literature, but we are, and we need to share it with them in order for them to change their best practices so that they are more willing to make that diagnosis and their referral over to their hearing healthcare specialist of choice. Frequently, we leave out a discussion on side effects for the treatment plans that hearing healthcare can provide. I'm just going to briefly touch on a few of them that I need you to be aware of so that you're not surprised by questions from nurses and doctors. Because there are some situations that do arise in the treatment of hearing loss that we should be prepared to deal with in a spirit of openness and trust. The first one is anxiety related to the use and appearance of hearing aids. Now, depending on the patient, but if you were to fit a patient with a pair of pink hearing aids with purple polka dots on them, that would probably cause anxiety on the part of the patient, which may end up in poor patient engagement. In other words, they take those hearing aids out, they put them on the dresser, they don't wear them because they don't like the way they look. Some people get anxiety about just wearing hearing aids because they think it makes them look old. That the emotional reaction to being fitted with hearing aids is anxiety. And anxiety is a powerful emotion that will cripple your patients in terms of complying with the audiologist's direction for use as well as the physician's direction for use. Hyperacusis, another side effect of wearing hearing aids. Some people who wear hearing aids, they are sensitive to sound. They become even more sensitive to sound once they've been treated with hearing aids. And that additional sensitivity causes patients anxiety. It causes them to not wear their hearing aids. And we know that 30% of elderly patients do not wear their hearing aids. So we want to make sure that we're explaining to physicians that sometimes the patient doesn't understand why they're not wearing hearing aids. But if the physician is aware of some of the negative consequences of wearing those hearing aids, they can guide them to be more patient compliant. Another issue that physicians are not necessarily aware of, but we are, is the auditory deprivation effect that occurs when we treat monoaurally when binaural care is clearly indicated. So Stig Ollinger's article, The Negative Consequences of Uncorrected Hearing Loss, is a wonderful article for you to put in the physician's hands that explains the concept, and it allows us to validate to a physician or to a patient the reasons why we should treat binaurally instead of monoaurally, because then there are negative consequences associated with that. And another side effect of the use of hearing aids that physicians sometimes are aware of, sometimes nurses are, sometimes they're not, is irritated ear canals. If they get irritated enough where the tissues are tender and the inflammatory process kicks in, and sometimes infection results from an improperly fit pair of in-the-canal hearing aids, that's something that we need to know about immediately, and that's something that we need to advise the physician about immediately in case the infection is severe enough to warrant the use of an antibiotic. I think if we are educating the doctor about these things, it enhances our credibility and enhances our reputation for our profession. Cost of treatment continues to be an issue in audiological patient care. Many physicians and their staff members are aware that hearing aids can be expensive, especially for the patient with profound hearing loss. But very few know the basic facts about the cost benefits of hearing health care or the use of hearing aids. And this it obligates us as a profession to educate the physicians so that we educate the physicians and nurses so that they are obligated to make that diagnosis and that referral to a hearing healthcare specialist. Now, Care Credit is one of today's sponsors, and I want to add a comment here that I usually advise physicians and nurses about when it comes to financing hearing aids and making it easy for people to get the care they need. And the statement that I usually make is that Care Credit helps minimize the ratio between the patient's income and the patient's outgo when they're fitted with hearing aids, so that they're comfortable with that monthly payment, so that it doesn't become a financial burden, and so that the benefits of wearing the hearing aids outweighs the cost of the monthly payment. And Care Credit does an ideal job of doing that for all of your patients, doctor. So I'm frequently asked the question, how does treating a patient for hearing loss benefit the doctor? Well, I want to talk a little bit about improved patient engagement and compliance as one of the benefits of making sure that the doctor's patients can hear the physician in the exam room. 1 in 5 Americans cannot hear 25 dBs in their worst ear, which may cause communication issues and affect their quality of life. It makes it more difficult for the patient to be engaged in following the doctor's orders. So that in the exam room, if the patient cannot hear the doctor, if the patient is unable to get to efficacy because of that communication barrier, we in audiology can do something about that. We can be a positive contributor to that situation. We need to articulate the benefits of treating their patients who suffer from hearing loss, being improved communication and improved patient engagement. and thus we help the doctor more readily attain efficacy with that patient. Another benefit for the patient and for the doctor that results from the treatment of hearing loss is the reduction of the risk of developing depression. In the United States, approximately 10% of the U.S. population suffers from depression. In the patient with untreated hearing loss, it is almost 12%. Now, the slide here shows 11, but it's between 11 and 12%. That's an astoundingly surprising and important, statistically significant difference that physicians need to be aware of. We're not going into doctors' offices pretending to be psychologists who can prevent the risk of or prevent the incidence of depression. What we are doing is explaining that depression can result from untreated hearing loss, and it can affect the doctor's ability to get that patient to efficacy, because people who suffer from depression are 3 times more likely to not be engaged in their care. And the last thing the physician needs is a patient who's not engaged in their care, because they can't get them to efficacy, and thus improving their quality of life, and thus lowering the cost of care. So we need to make sure when we do our patient intake forms that we ask the question, have you ever been treated for depression? Because that depression may be related to untreated hearing loss, and it may be a significant benefit of the treatment that we provide. And physicians need to be aware that that's one of the benefits of the partnership that results from between them and a hearing healthcare provider. 1, we can help make sure the patient can hear, and 2, we may alleviate an important cause of depression that interferes with the doctor's ability to have that patient engaged enough to get to efficacy. So better hearing does mean better health, and what do I mean by that? Increasingly, hearing loss is being linked in the scientific literature to a large number of chronic conditions resulting from lifestyle choices. Some of those are shown on this page. There are chronic conditions such as diabetes and prediabetes that are independent risk factors for hearing loss. In other words, there is a causal relationship between hearing loss and diabetes and some of these other factors that you see here, such as cigarette smoking and passive smoking, cardiovascular disease, hypertension. Some of these comorbidities are brought about by lifestyle-related behaviors that ultimately contribute to the development of hearing loss, which ultimately results in the staggering numbers of U.S. citizens who suffer from hearing loss and cause this epidemic-like chronic disease that 80% of the time goes untreated. So when we partner with the physicians, one of the responsibilities that we've had, as I mentioned earlier, is this educate to obligate marketing strategy, communication strategy about these comorbidities. Bring the clinical research articles to them. Don't highlight them. Let them read it. They can make their own analysis, but you should certainly be prepared to identify the key passages in these clinical research articles that can make a difference in the patients being treated by the doctor, can make a difference in their quality of life, can make a difference in their overall security and personal well-being. For those of you who are listening today, I am readily available to provide clinical research articles on these topics that will allow you to take them into doctors' offices and educate the doctors and nurses about them and the role that they play in the development of hearing loss. So we have an obligation, as I've said before. Physicians will not necessarily be quick to see you. I would ask you to think about being a solution-oriented optimist in the long term and a solution-oriented realist in the short term, and that you will succeed with sheer persistence and attention to detail and fulfilling our role as educators and as partners in patient care with the primary care physician community. Another reason why it's important for us to show up to the doctor's office is with patient education material that they can give out to their patients so that patients are more informed about the disease state of hearing loss. In the United States, according to research that's been published by Harvard Medical School, only about 12% of patients understand what the doctor is saying to them. They don't understand the language of medicine. Sometimes they can't hear. Sometimes they're depressed. But we can help improve that situation by making sure that we are doing our part to help improve poor patient literacy as it relates to the disease state of hearing loss. As an industry, we can go to the National Institute of Health, NIDCD. You can Google that address, and you can order high-quality patient education materials that are free to you, regardless of quantity, regardless of the number of times that you place your order. These educational articles can be placed in the outer office so that patients can read them while they're waiting and self-refer, and they can be given to the nurse, medical assistant, to be given to the patients when they come out of the exam room and the doctor has determined that they need a referral for the treatment of hearing loss or tinnitus or a balance disorder or earwax removal or hearing aid repair or any one of your multiple services that you offer. So I encourage you to order as many of these topics that they have. They're available in English and Spanish, and that's an important part of the service that we provide in doctors' offices. I thank everybody for their attention today. Now I would like to pass the baton with today's webinar over to Brad Dodson, and he will continue the program from this point on. Thank you very much again to the Hearing Review and to CareCredit for sponsoring today's program.
Thanks, Bob. Thanks for the great information on how to approach and gain the ear of physicians. No one does it like Bob Tysoe does, so thank you so much, Bob, for that part of the presentation. I'd also like to thank CareCredit and the Hearing Review for hosting this webinar. My name is Brad Dodson, and my piece of this is communicating with physicians and their patients, utilizing digital technologies. You guys are already using digital technology in your everyday, outreach and marketing efforts to patients, and I'd like to bring some of that now into working with your physicians in your local community. I think you're going to be very excited to see some of these technologies available, and of course I'm always available if you have any questions about incorporating this into your existing marketing plan. So let's get started. So I'd actually like to get started today on the actual statistics themselves. So according to Statista, one of the leading statistic companies on the internet, for 2017, the number of smartphone users in the United States is estimated at 224.3 million. That's 80% of the U.S. population, according to the Pew Research Center. In addition, IDC says that 80% of those folks, likely both you and I and the physicians in your community, checked email before their first cup of coffee this morning. Phone and social media aren't the only way that doctors communicate with one another or their patients either. Actually, 62% of physicians and other healthcare providers prefer communication via email in comparison to direct mail, phone calls, and in-person visits, according to MedData, which is a medical technology marketing and industry trends report. So if you're trying to generate more referrals, then I hope you've implemented an email marketing campaign to complement your current outreach efforts. If you haven't, then you're probably part of the 40% of healthcare companies mentioned in that very same report who have not implemented an email marketing strategy directed at physicians. And furthermore, according to the same report, 75% of physicians use smartphones and tablets for professional reasons, and that checking email is at the top reason for using these mobile devices in the workplace. So if you've been trying to reach another doctor and they haven't responded to your voicemail messages or letters, you might want to try an email instead. Layered marketing. Let's dig into that a little deeper. What is it, and how can we apply this concept to physician outreach? Multi-channel marketing has emerged as the best way to communicate with your audience. It's all about maximizing opportunities to interact with your prospective patients. And in this case, of course, a channel is not an industry vertical, but a marketing vehicle like email, a print ad, a retail location, a website, social media, a promotional event, a mobile app, or SMS messaging, your product packaging as an example, or word of mouth, to name a few. With the internet and mobile devices getting smarter, we research, shop, and review differently. Therefore, there is no longer only one way to advertise. You need to be flexible and diverse in order to reach your elusive audience. Build it and they will come will only get you so far. Today it's more about the right ad at the right time. You have to engage with your audience multiple times in order for them to purchase a product or service from you. A multi-channel approach is essential for standing out as thought leaders and working with the physicians in your community. Here's a great example on screen right now about a layered HCP outreach program. Knocking on doors, as you heard from Bob Tysoe, is still the most important part of physician outreach. You have to build that relationship, and that continues for the life of your practice. Are you sending patient reports? Are you asking for the patient's PCP info at intake? Sending emails to all the physicians in your local community on a monthly basis. Include your nurse practitioners and physician assistants. There's always more than one person making decisions in that practice. Make sure you're getting analytics for your email campaign to track which doctors are interacting with your outreach. Access physician mailing lists that correspond to your email list to follow up with personal letters of introduction, and speak directly to the patients waiting in the physician's waiting rooms as well. That all encompasses this layered approach to making sure that your physician outreach, utilizing other digital marketing strategies, has the best chances of being successful. It's also very important to note that financing options play a big part in working with your physician community. Physicians are less likely to recommend hearing care if they perceive that hearing aids are too expensive for their patients. Letting them know that there are financing options like care credit is absolutely going to be good for your practice. So here's a question I'm sure you're all thinking. Are physicians opening and reading emails from hearing professionals? So with over 15,000 emails already delivered by hearing professionals, the data suggests that MD emails achieve a deeper level of engagement relative to other forms of digital media, as a substantially high percentage of physicians read rather than glanced or skimmed the articles presented. And you can see on screen the click-to-open rates for various different specialties. The recent MD email physician marketing campaign for a large practice in the Pacific Northwest yielded a read rate of just under 70%, which is astounding numbers for any digital marketing effort. In addition to a high number of clicks to open, a significant advantage of email communication is that your message can be tailored to any medical subspecialty, further building your reputation as a respected member of the medical community. Let me talk a little bit about some of the challenges of effective email communication with physicians. This will give you a bit of an overview of what to look for and what you should be focused on when preparing a email campaign to the physicians in your area. And we'll stick to three very important ones to keep it concise. The first and most to a successful email campaign is getting your message delivered to the inboxes of your target audience. No easy feat. You have to make sure that these emails are properly spam scored in order to reach them, and there are some very specific email guidelines to ensure that they are getting through some very tricky, what we call filters in place and spam filters to reach these physicians. Using a approved list or licensed list like the American Medical Association are the best places to start, and absolutely help in accessing that data is something I can work with you on. Emails coming from licensed vendors of the American Medical Association have a 98% deliverability rate, and primary purpose, obviously, of a successful campaign is to make sure they end up in the inboxes of the physicians. After that, it's all going to come down to a few other things. Secondly, it's about the call to action, the CTA. We've all heard that word, and it is very important not only in this, but in all the advertising that you're doing, and email is no different. The call to action is arguably the most important component of an effective email. It's how leads are nurtured and sales are closed. So what makes a good CTA? There are several best practices that can improve your conversion rates. An example, first of all, is keeping it short. The most effective call to actions are just 5 words or fewer. Communicate your value proposition with clear, action-oriented language using words like register, download, or request. Create a sense of urgency or time sensitivity with words like today or now. And place the CTA in a prominent place above the fold. Use only one CTA per email. HCPs make decisions all day long. Don't invite inaction by asking them to decide between several call to actions. And thirdly, and most importantly, they have to be mobile optimized. As you can see on the screen right now, based on that same campaign that was sent out a little while ago, 75% of the physicians reached, we're talking 3,000 emails were sent out, 75% read the email on their mobile device. 17 skimmed it, and only 7.5 glanced at it. And look at the desktop, 51, we have a 68 total across. So mobile is absolutely the place they're seeing it. So making sure that your templates and at least your emails themselves are mobile responsive. The majority of HCPs are viewing emails on their mobile devices. Of those who do, most are using Apple products. So if your emails aren't optimized for mobile, there's a good chance that they won't be opened. Okay, so you are extremely busy, How do you bring this all together for a successful physician email outreach campaign? We'll take a look at a program called MD Emails right now that is making that all a lot more simple for you. As you can see, marketing to physicians is no easy task. Not only are they hard to reach, but they have limited attention spans for content that doesn't immediately resonate with them. MD Emails is an email design and delivery service used to educate the physicians in the hearing healthcare provider service area of all the positive results of properly treating hearing loss. MD Emails taps into the power of physician marketing experts like Dr. John Bucky, a graduate of the University of Pennsylvania Medical School and trained in internal medicine at the University of Chicago. Mr. Brian Taylor, AUD, one of our co-presenters here today, and Bob Tysoe, again, who just presented before I did, owner of Hearing Healthcare Marketing Company. Bucky, Taylor, and Tysoe's credible and persuasive words, written in the language of medicine, increases the likelihood that the physicians will want to open the email. I think that's important to digest a little bit more. We are not trained to write in the verbiage needed for physicians to really grasp, I think, some of the concepts that we need to do. So it was very important for us to bring in some professionals who've done this for a very long time and have had results in their communication directly with physicians. The next part of it is making sure the content is valid and the content is creative enough and designed specifically to attract the attention of the physician, and then, of course, analytics, which we'll get into in a moment. It takes a combination of well-written content and simple mobile responsive HTML introductions to get the attention of the physicians in your community. But it's an ongoing effort that you can personalize as you go. So just think how effective a perfectly timed email would be addressing topics like hearing loss affects more than just your patients. Hearing loss and perhaps insert any comorbidity are closely linked. Click here for more. It's not just your patients that are affected by hearing loss. Let's work together to improve patient-physician communication. Those are some terrific topics that are pertinent to a physician's practice immediately. And their response to that will be heightened because of the relevance of the topics and relevance of the content. So the best campaigns are personalized and include several variations of core content repurposed to speak to the unique needs of the physician in your community. It takes a two-step approach. It's an email that's very specifically designed to get through spam filters and get directly to the physician. In addition to that, the ability to download information that's personalized, specific to the topic and the relevance of the topic that you are presenting to the physician, and being able to utilize that in your outreach and work directly with your physicians so they have some takeaway from some of that outreach seems to have been the best approach for us. So being able to come together with your topics that are, that you feel are very important for your marketplace. I've heard a lot of conversation about dizziness and how a lot of folks who are reaching out to the physician community are finding a lot of success using topics like dizziness, because very often someone walks into a physician's practice and just says, it goes to see their PCP and says, I'm dizzy, I don't know what's going on. So they're trying to find ways in which you can really connect with that patient base and allow the doctor to be able to go through some of these emails that they're receiving, perhaps as just a newsletter-based service to them, updating them on all, maybe some of the changing landscape in the hearing community. I think that's very pertinent, especially with some of the changes that we all know are pending, making sure that physicians understand the difference between that, and educating your physician community, I think, is a terrific service. What I'd like to talk about now is how we add an additional layer to talk directly to the patient as well. We talked a lot in the beginning of this presentation about mobile usage, and I'm going to dig a little deeper into the idea of using mobile devices and being able to not only do emails to the physicians, but also work with the patients sitting in the waiting rooms as well. I think that this is a terrific add-on to that program, utilizing mobile technology, which is the fastest growing sector in advertising in the country right now. So what about the patient? Aren't there two people in every healthcare decision? The answer there is yes, of course. That would be very accurate. So how do we target patients in healthcare practices? Have you heard of geofencing? Or how about location-based marketing? Let's start at the beginning. What exactly is a geofence? A geofence is a GPS-enabled electronic barrier that allows medical practices to send location-specific messages to potential patients' smartphones once they enter into the defined geographic area, which can range in size from a single building to an entire city what we term as a DMA or zip code. Smart fencing, which is another term for it, will send an electronic beam from a satellite. That beam creates an invisible fence around a set location, around an address, that will have control over determining what ads are delivered. When someone crosses that fence with a smartphone or tablet, and they open one of 200,000 plus applications, we have access to being able to send them an ad specifically from your company. Spending on in-app advertising is expected to reach $17 billion by 2018. According to a report by Juniper Research, this amount is up dramatically from about $3.5 billion spent in 2013 and makes in-app advertising the fastest growing sector of the mobile advertising market. And now, thanks to smart fencing, you can get a piece of that opportunity to reach to those smartphone users for your practice. Within the world of mobile advertising, experts view in-app advertising as the future. What is the difference between in-app and Google Adwords? I'm sure that's a question you've had. Browser-based marketing or search engine marketing relies on the browser to enter keywords that fit your criteria. In-app marketing, though, allows you to deliver an ad to an app we have access to either in a fence location or based on a consumer's previous visitation data. In-app advertising is ideally more effective because it enables advertisers to target people with the right ad at the right time. We talked about that earlier. Advertising and layering is becoming more important for right place at right time than it is just sending out en masse. And I think this gives us a little bit more control of that, capturing their attention without being annoying, encouraging interaction, giving them greater control over the situation. So being in-app, for instance, you're on the Wall Street Journal, or you're looking at your WeatherBug or your FitnessPal app, being able to access through those applications is very, very important. Through smart fencing, you can target a specific demographic of patient as soon as they set foot inside your assigned geofenced area. So how do we target your audience? How do we target those elusive baby boomers and beyond? I have the slide up here because I think it's important to show you that our audience is absolutely using smartphones and mobile devices. You can see on the screen the 55 plus on the top right-hand side are spending anywhere from 32 to 38 hours per month in-app, accessing 22 to 25 applications per day that they're moving through. And further down, as far as 55 plus is using or clicking on digital ads that are popping up in applications, 48% of those particular users have no problem clicking on those ads. So you have two options when geofencing to target a mobile device. We'll keep this in the context of the physician marketing, but obviously you can target just about any behavior that you can think of. We have about 90 segments that are already created, or you can target by location, otherwise known as proximity. So as a location audience, you are targeting in real time, and it's based on where a consumer is currently located. In other words, where they dwell. This is ideal for reaching consumers at the right moment to influence their purchase behavior as consumers move throughout their day in the physical world. So with behavioral targeting, which is slightly different, we are targeting based on a historical location or their historical location information. So yes, very big brother, as you're walking out throughout your day with your mobile device on various applications that you enjoy surfing on throughout the day, all of that location information is being beamed up and then bucketing a lot of those mobile device IMEI numbers into certain segments. For behavioral, what that just means very simply is that you perhaps visited Starbucks, you then went to the gym or gym and then Starbucks, and it starts to place you in these certain segments based on your previous visitation behavior. This targeting strategy will help us target the right audiences. It will ensure we are reaching audiences that have exhibited the visitation behavior the client is interested in reaching. For instance, I want to target someone who's been to a Costco pharmacy in the last 90 days. That's just one example. There's clearly a whole bunch of different topics, baby boomers, casino goers. But that just gives you some examples. We can obviously target very specifically. An example here is the surrounding areas around a football event. There's over 12 million businesses and points of interest that have been geofenced and blueprinted so that they can pick up a lot of this visitation behavior. And I think that's important. If you wanted to target folks who've been to a football game recently over the last 90 days and have a targeted ad about hearing loss and loud noises, that's absolutely possible now with geofencing. probably one of the largest parts of all of this is the analytics side of it. And it's very important to stress that you need to make sure that you're focused on what's being delivered. Make sure your mobile targeting strategy includes useful, insightful analytics for you to make better informed decisions for future campaigns. It's very important to see your ad performance not just by the creatives you are serving, but by the actual geofenced addresses. You might have a list of doctors, as an example, that send you referrals, and you want to target their patients separately to all the other physician areas that you don't get referrals from, so that you can, absolutely see which messages are resonating with each of those different patient bases, perhaps, or perhaps by specialty. Are you getting more from cardiovascular doctors or more from endocrinologists? So make sure that whatever you're doing, there's definitely some useful analytics for you to track what is going on with some of those marketing decisions that you're making. All right, so in closing, I'd like to recap some of these additional layers of marketing for you today. My presentation today was about reaching physicians and their patients using more digital technology. So to recap these layers, it's important to inform and educate the HCPs in your community with customized and targeted email campaigns. Those can be designed specifically to represent your brand, represent who you are, and really allow you to make maybe a different, more educated connection with that physician. And it's not to replace the outreach you're currently doing. It's a terrific additional layer so that people within the community and the medical community know that you are a thought leader and a participant. Act on analytics and reach out to the engaged HCPs. Make sure that your lists include names of HCPs and just how much time they're spending on these emails. Leverage known lists like the American Medical Association. Their license lists are very, very expensive, but they are the best way to make sure that you get your emails delivered. Geofence all of the medical practices in your community or service area. Keep consistent messages to their patients about hearing loss and the fact that it's not a harmless condition. Leverage behavioral targeting to target your audience based on previous visitation data. So you can do it either through a geofence, which is an address and proximity, or you can target based on some of that previous visitation data, like everyone who has been to a pharmacy, for an example, in the last 90 days. And then continue to add more digital layers to your current physician and patient outreach efforts. I think these are just two layers that you may not have been very familiar with, and I'm hoping today's session gives you some more insight there. So thank you so much for having me here today.
Thank you, gentlemen, for those great presentations. If you have any questions for the presenters, you can email them at the email addresses shown here. This webinar was brought by Hearing Review courtesy of CareCredit. For more information about CareCredit's great offerings, you can visit carecredit.com/practices/hearing. I'd like to thank Dr. Brian Taylor, Bob Tysoe, Brad Dodson, and CareCredit for their participation in this webinar. For the Hearing Review, I'm Carl Strum. Thanks for watching.